So good afternoon, everybody. For anybody who I haven't had a chance to meet and get to know yet, my name's Dan. I work at the Department of Health. My title is the CDIO, Chief Digital Information Officer. And I'm going to talk to you today for maybe half an hour or 40 minutes and leave hopefully a good period at the end for questions. We've got a fairly small group dialed in so far. We might find that increases as people get a chance to grab a cup of coffee and a butty and dial in. Or if not, then this is going to be a good small group, and we can maybe get a few questions and people will feel comfortable jumping in as we go. The topic for today is effectively an end of term school report, really, on the work that we've done in digital in the financial year that's just closed as of this morning. We're on the 1st of April, so it's FY 21-22. I'll just share my screen here. Here we go. I'm going to be using some slides to talk to you guys during the course of the presentation. As a quick reminder, these digital dispatches sessions, and thank you all for your time and attention today, these digital dispatches sessions are part of our communication strategy in the Digital Health and Care Northern Ireland team. In the last couple of years, it's been difficult to bring people together in the traditional way of sharing thoughts and ideas and progress and having large rooms full of people together. So this is our effort to try and make sure we stay connected to colleagues across all of the technology teams, but more broadly across the service. And these digital dispatches sessions are a totally transparent and open invite for everyone to come and hear about topics that we think are interesting. If you don't think the topics that we've chosen are interesting, then it would be worthwhile giving us that feedback. If you have questions while I'm talking, then do feel free to pop them into the chat window, and one of the team, maybe Jen, or if Linda's on, they can decide whether it's worthwhile interrupting the flow to feed your question in context, or whether we'll store it up and have that be part of the discussion that we'll leave time for at the end. There are three things that I would like you all to take away from this next hour or so that we spend together. Firstly, a point I've already mentioned about transparency. We're putting an awful lot of the taxpayers' money into digital in health and care in the next few years, and we need to be totally open with all of our colleagues across the service as to what that looks like and why we're doing it. So you'll hear us talk a little bit today about how we're setting budgets and prioritising the investments. The second point is that we've got some really big ambitions as individuals, as organisations, and collectively, and we're making really great progress on delivery. But also, it's worth recognising that we've got some amongst those big challenges. We've got some work to do and some things to wrestle with, and we're doing that generally successfully to overcome some of those challenges. And then finally, my third point I'd like you to take away today is that we are getting increasingly better. We're improving our choreography of the portfolio of work and the supporting financial plan, in particular with the agility that we need each year to maximise the bang for our collective book on our digital investments. So inevitably today, I'm going to talk to you about the work that we've been doing over the course of the last 12 months. And as I was preparing materials and preparing what I was going to say to you today, at points it feels a little bit like lists of things, which is a bit dull. So what I'm going to try and do as we go through some of those accomplishments is bring it to life with the impact that it has on our staff, on people who work in the service in Northern Ireland, and our service users, as well as some descriptions of how the accomplishments and our processes and governance models work collectively to deliver outcomes for our people. So that's my plan. I hope that's going to be interesting for you guys. And as I say, jump in with thoughts and questions as we go. So the sort of end of year report, if you like, that we're going to talk about here I think there's 4 moments in time that are worthwhile covering. Firstly is what we said we were going to do this year, so that we can reconcile back against our intentions. So the going in plan position for FY 2021-22 is going to be my sort of starting point as I orient us, and then talk about how we've gone against those original plans. The second thing that I'll go through is the progress that we've made and some of the challenges that we've faced and overcome during the year. And the third bit of the conversation today is going to be where we find ourselves now. It's the 1st of April, Happy New Year. It's the beginning of FY 22-23. So how did we get on, and what could we do in terms of stock taking against our progress and where it got us during the course of the last 12 months? And then I think it's useful for all of us to just think about what happens next, what's coming in terms of our priorities for FY 22-23. So that's the running order for the conversation today. Thinking about the first item, what do we plan to do this year? The DHCNI plan for 21-22, this document here was approved at the DHCNI board, the Digital Health and Care Northern Ireland board. So on our governance framework, that's this meeting here, and it includes chief executives of trusts and arm's length bodies, SROs of our major programs, and other deputy secretaries like me on the Department of Health Executive Board. And that meeting happened back on Friday, the 26th of March, so just a little over 12 months ago. Before I go on to what they agreed to in that board meeting, and I know that most of you already know this, the way we set out our budget profiles for digital investments is in 2 different types of money. Capital is the money that we spent on purchasing assets that support delivery of services and activity, and assets controlled by an organisation that buys it and is used typically for more than a year. And assets include things like buildings, computers and other computing equipment and software. Revenue or resource expenditure is the day-to-day running costs, including staff. And any expenditure that doesn't meet the definition of capital is considered to be revenue. So as part of our FY 21-22 planning processes, along with colleagues in the Department of Health Finance Directorates, we secured up to about £128 million of capital. And there's some caveats in there about pending business cases that need to be submitted to the department within in-year spend, and about £28 million of revenue money, including resources over and above our previous baseline amounts. So in total then around 156 million of investment in our digital infrastructure systems and transformation is what got signed off at that DHCNI board just over a year ago. So to give you a sense of the number of individual things that we planned on covering, there were 44 items, some of which in themselves were categories of sub-items to which capital had been allocated in the plan. To attempt to simplify presentation of this, we used a technique that recognises that the top 30 biggest items account for the majority of the spend. So in a sort of top of the pops, top 30 style, we'd used the 30 big things to try to illustrate our plans more easily to our stakeholders. So I'm going to show you this eye test that's on the screen here. It's an incredibly detailed table. You don't need to worry so much about the individual numbers. You can see that there's this list of 30 big things in descending order of size, and that the overall total accounts for most of that planned budget that I mentioned a moment ago. I'm going to pick out a few things that most of you will recognise, and maybe a few things that you'll be less familiar with. So firstly, we have the big electronic medical record replacement program called Encompass. So that's about replacing a whole bunch of legacy systems and technologies that we use across secondary acute care, mental health services, community care and social care with this single electronic integrated converged medical record across the region. I'd be surprised if you hadn't heard people talk about Encompass, and that's the majority of the investment that we'll make every year over the course of the next few years. Two things then I'll mention that you will be familiar with as well, I suspect, is the pathology modernisation programme and its constituent technology transformation called LIMS, which is the Laboratory Information Management System. That's where we completely transform how we do ordering and fulfillment of pathology and laboratory services. I'm going to flip over DSS for a minute, and I'll come back to that. The other one that's similar to NIPIMS is NIPACS. That's the replacement of our picture archiving and communication system contract that we have with Sectra in Northern Ireland, but also completing the journey towards a single medical imaging platform in the region, including replacement of the Philips and GE contracts that we have in the Belfast Trust, so that we can move towards that single integrated platform. Going back a step then to what a year ago we'd referred to as DSS, and in the last 12 months we've rebranded as HSC Digital. That's the program where we will be moving from multiple individual discrete technology teams across organizations in the region to that single organizational entity. I'm just going to admit some latecomers here. That single organizational entity that will manage all IT on behalf of the region in a converged way, but federated out across delivery locations that exist today across the trusts. So that's HSC Digital there. A couple of things then that you might recognize a bit less, that perhaps we've had a chance to talk about a bit less as a region, would be around our investments in improving our DHCNI capabilities. So all of the data that I'm going to talk to you about today comes from our Enterprise Portfolio Management Office and its management of the portfolio of digital investments. And that's a fairly small team given the ground that they cover. So as we went into this year, we had intended to invest in additional capabilities for that team. And then another final one that's maybe less well known is the implementation of SNOMED. So for those of you that don't know, SNOMED is a fairly widely adopted clinical terminology approach to define the things that are wrong with our patients and the things that we do with them to address the things that are wrong with them. So it's the ontology for describing the work that we do as a sector. And the Encompass Epic solution uses SNOMED, it speaks SNOMED. So a lot of our other systems that don't speak SNOMED need to be updated or integration technologies deployed so that we have the ability for systems and layers within our delivery structures to be able to talk to one another. So that's just a bit of a flavor of what we had in our plans for this year, calling out a few examples, some known and some less well known. It's worth saying before we move on, and that as we went into FY 21-22, the last 12 months, we had already had to make some fairly challenging prioritization decisions. A decision to invest in one thing, given that we live in a world of constrained resources, means that there's less budget to invest in something else. So just to give you a flavor of some of the things that we had to prioritize against, the Northern Ireland Electronic Care Record project had reached the end of its life cycle and business case funding. As part of the project, staff were funded at the trusts to make use of NIECR functionality for additional patient benefits, like accelerating the availability of diagnostic and discharge information to GPs for timeliness and improvements in patient safety. And there was a challenge in finding a revenue budget this year to be able to continue funding trust side staffing. And that was the knock-on, the kind of corollary of that was it was going to reduce our ability to drive strategic improvements for patients and staff, while NIECR still is our longitudinal integrated care record in the province before we move on to the Epic solution. Thinking about Encompass again, there are a number of projects that aren't necessarily directly required for the Epic solution to go live, but they're needed for the program to deliver its full range of benefits. They're called the Encompass enablers. Some of these are more urgent than others. One of them, for instance, the data archiving project. As we switch off all of the systems that Epic will replace, what do we do with all of the data that remains in those systems so that we have a strategic and accessible archive of that historic clinical information, as well as our ability to then sunset those technology solutions that are being replaced and therefore deliver the benefit of a reduced technology estate and associated costs. So we didn't have funding to be able to commence what we refer to in the digital teams as discovery work. So those early stage activities to do options assessment and design work. We didn't have funding to be able to commence, at least explicitly in our funding profile for this year, some of that work. So as you can see, as we go into each financial year, there's a pretty significant set of conversations that happen to prioritise the work that does make it onto the list. The next item in my agenda, having established a bit of what we did and importantly didn't intend to do in the course of these 12 months, I want to think now about the progress, the accomplishments and the challenges that occurred through the year. And as I do that, it's worth remembering that since the DHCNI board, that governance group I mentioned earlier, had their meeting back in March 21, there's been a number of developments with the COVID pandemic that continued to put pressure on the system, and it's required focus from all of our HSC organisations, and that impacted our ability in the digital space with the DHCNI team and its partners, BSO ITS and the Trust and others, to make progress. And I guess I'm just reminding myself as much as I'm reminding everybody else that those COVID events included some actually really significant things that just start to ebb away in terms of what we're worried about and thinking about on a day-to-day basis. So that the Delta variant, if you remember, wasn't classified as a variant of concern by the Public Health England gang until the 6th of May in 2021, so certainly within this financial year. And as you remember, the evidence at the time that it was defined as a VOC was that it was at least as transmissible as the Alpha variant, which was dominant at the time. And as we know, evidence subsequently emerged that Delta was significantly more transmissible than Alpha. And then tracking through the year, the Omicron variant was classified as a VOC on the 21st of November. It feels like ages ago, but actually it's remarkably recently that that's happened in the history of the last 12 months. And initially that was seen as at least as transmissible as the circulating variants at the time, Alpha and Delta. And there was the indication that mutations suggested it was going to be reduced in terms of our protections in the natural immunity space. And as we all know, since it was declared as a VOC in November, that all of the evidence emerged that it was significantly more transmissible than anything that we'd previously experienced. So I guess I'm just trying to remind ourselves of what's happened over the last 6-12 months as it relates to the pandemic. And yet, in parallel, we've been able to do so much. So just to give you a bit of a counter through some of the things that we have done, the commencement of the development of the new health and social care digital vision and strategy, and pretty extensive engagement with staff and citizens on the future of digital enabled services in our sector. And I'm going to talk more about the vision and strategy in a later section of my talk here today. We continued with the implementation of the enterprise portfolio management structures and processes that I mentioned a moment ago, including completion of the integrated portfolio plan and associated critical path analysis. And that team, the EPMO guys, some of whom are on the call today, also made great strides in improving cross-program management of major issues, risks, milestones and dependencies, as well as improving the working arrangements with all of the project managers leading the major programs and projects, which is helping to identify synergies and share good practice and ownership of the overall portfolio plan. We've also made great strides on the new Microsoft Enterprise Agreement, renewing over 60,000 existing operating system licenses with O365, this new way of approaching licensing that brings with it new collaboration and productivity tools, and refreshing over 8,000 Microsoft server licenses, as well as achieving a federated identity directory, and from that accelerating preparations and commencing earlier than we'd expected the rollout of the Microsoft Teams application. If you haven't had it yet, it'll be in the pipeline for you and your organization shortly, and is a big step forward so we can stop talking to one another on products like Zoom and all move onto a converged collaboration environment using Teams. We've continued development of new and iteration and support of already developed COVID products, back to my point about the pandemic, and I'm going to cover that a little bit more in a wee second. We've also commenced the progress of handover of those digital products to the Public Health Agency, which is the rightful long-term owner for the health protection services that we developed during COVID. I've talked a little bit already about Encompass. So the Encompass programme, I suspect most people have heard some of this, if not all of it. It's had some challenges during this financial year. And another one of our big achievements has been in stabilising the programme, including bringing in a new SRO and supporting the team during the absence of the programme director, bringing external experts into the programme that have done this before to accelerate delivery tasks, strengthening and working collaboratively with the strategic advisory group to make informed decisions, helping to define more clearly the relationship between key partner organisations like BSO-ITS and BSO PALS and the programme team and its plan, and pushing ahead on delivery of key items, like, for instance, the launch of the procurement for the infrastructure environment. We took a sensible pause related to Omicron. We've dealt with the implications of that from a planning perspective, arriving at a new go-live date for the first trust, the South East Trust, which was originally due to go live actually at the tail end of this year, calendar year that is. It had been moved in the early stages of the pandemic to March 23, and we're now looking at an after summer date, so probably September, October 2023 for the first go live. In parallel to the progress with Encompass, we've started to make some of this progress with those Encompass enablers that I talked about a moment ago, and we've initiated a good bit of work on the digital dictation solution and the learning management solution, as well as starting to do work on the assessment and discovery of that need for that archiving solution that I talked to you about already. We have finished the procurement work on NIPAX Plus this year, and we are well on the way with the planning of the implementation project for rolling out that new solution across all of our sites in Northern Ireland. We've approved the business case for the LIMS, the NIPIMS, the pathology transformation, and we're well on the way again with plans for implementation of that with Clinisys as the vendor. We have continued to work on infrastructure. So we've done a refresh of a lot of the equipment that's in the Northern Ireland Health and Social Care Data Centre, moving towards a more up-to-date and refreshed technology estate. We've done implementation of a number of cybersecurity measures, including further rolling out of products that we started to roll out a couple of years ago, given the changing threat landscape, and in particular, the increasing threats from ransomware attacks. And really importantly for the future, we've developed a new strategy for cybersecurity, which has been approved at all levels now, and moved into the development of the business case for implementation of those strategic measures to further secure our information and systems. We've developed a business case and submitted that, and just recently, I think it was Friday last week, got a approval in principle of that business case from the Department of Finance for replacement of all of our back office systems. So you would know that as FPL and HRPTS, and we're going to be under the EQUIP programme with its now approved business case moving to a cloud-based ERP single converged platform in Northern Ireland, which is a huge programme of work over the next few years and will make all of our lives a bit easier. We have continued to replace the telephony and integrated communications and control systems and voice recording for the ambulance service. And we have furthered our work to support and maintain hardware and software for GP practices in their management of patients and improvements for streamlining of care. So just a huge set of achievements this year from a digital perspective. I talked a moment ago and earlier on about the C word, the COVID pandemic, and it is kind of hard to talk about the last 12 months without thinking a little bit about COVID. Our response in Northern Ireland saw us build a dozen completely new digitally enabled and mostly public-facing services on a once for Northern Ireland basis, and doing that required adoption of a bunch of things that were fairly new for us, at least at scale at the regional level in health and social care. So I'm thinking here about things like cloud technologies, smartphone app development, agile delivery, UX and service design. And the reason that I mention this here is that our experiences in developing these new services are shaping our future vision and direction. And we've been trying to make smart architectural decisions throughout all of this so that we can maximize reuse of these investments in the future beyond the pandemic. I'm not going to talk about all of these services, because likely if you've been tuning into the work that we've done over the last year, you'll have heard the team talk about these before. I'm just going to mention a couple of items from this year's progress. Firstly, the vaccine management platform, which is the booking and point of care systems for vaccine delivery. It provides Northern Ireland's first region-wide health and care citizen-facing appointment capability, and our first once for Northern Ireland clinical data capture and workflow solution that's delivered across all locations and facilities. I'll talk a little bit here also about the COVID certification service. So this was the app and the associated back-end systems and infrastructure to provide citizens with evidence that they're vaccinated and safe to travel. As part of that one, we've had just under, in fact now just over 900,000 people, about half of our population in total, that have registered for a new LOA2 authenticated digital identity. So that's a strong digital identity that allows them to interact as citizens with services that contain and communicate identifiable patient information that has that extra level of information governance consideration around protection and security of that information, and how and on what basis we can share it with citizens. So we built that in partnership with the teams at NI Direct, the Northern Ireland Public Sector digital portal that I'm sure most of you are familiar with. So the strong digital credentials can be used in the future to access any number of public services, including continued relationship with them on delivering access to health data and systems. So this new digital identity management component uses artificial intelligence to do the automatic validation and uploading of identity documents, as well as a moving selfie, with over 90% end-to-end automation, which is the best that has been achieved as far as we can see, certainly in the UK and probably in Western Europe. It also establishes the information architecture and legal framework for, on behalf of applications for minors and for people with additional needs to be transacted and data access to be granted at a once for Northern Ireland level again with parents and carers. And this whole thing provides a huge leap forward for health and social care to provide convenient, modern, integrated citizen-facing services. So some big strides forward for us all there in terms of that work that we've done on COVID. The next thing that I want to talk about is our digital vision and strategy. So I mentioned earlier that we've been busy on that work this year, and we've been creating this thing that you can see on screen here, the Northern Ireland Health and Social Care Digital Vision and Strategy. It puts us on a really ambitious trajectory, and if we get it right, it could have pretty far-reaching impacts on our patients and our client services, more so than any other health economy in the UK. We are in the process of setting all of this out in this document, and that's due to be completed and ready for socialization in April. So all of you should look out for communications, and we're going to take an equally transparent stance with that in terms of gathering feedback and inputs, in addition to the engagement exercises that we've already gone through. The challenge that we've got is that the general election to the Northern Ireland Assembly is going to happen in early May, and PERDA, this process where we have to limit the new announcements that we put out, that's kicked in already. So we can't really launch the strategy in its entirety without a minister. So that'll come a little bit later in the year. But we're going to give you a bit of a sneak peek today at what it says in that strategy before we enter into this round of engagement and that full launch. The strategy development exercise has been inclusive and open, and has been a sort of co-creation exercise in partnership with citizens and patients, and really importantly with you guys, with our staff. And it sets out to make digital a fundamental enabler for everything that we do, and supports delivery of our overarching sectoral strategy, Health and Wellbeing 2026, this delivering together thing that I'm sure most of you are familiar with. And that includes our version of the quadruple aim in there. The strategy is being developed as part of a wider suite of documents that represents our overall digital transformation, and that includes a cyber strategy that I mentioned earlier, a data strategy that drives forward our use of insight and information as a service, and a digital innovation strategy. And those three things sit underneath the main document that provides more in-depth direction. And together, all of those things will continue to drive our digital investment portfolio over the coming few years. The strategy recognises that all of these technologies and programs are irrelevant, really, if we can't foster the culture change that's needed in our health and care system to reimagine the relationship between the patient or client and their health and care team, and put people at the heart of everything that we do as empowered partners in their health and care experiences, and use digital tools and data as a stimulus and opportunity to transform towards these consistent once for Northern Ireland services. The vision is for a future health and care system that leverages data to drive insights into our services, is digitally enabled at every step in every care journey, invests in world-class technologies, is agile, adaptive, and innovative. It brings the latest in diagnostic and therapeutic solutions, delivers personalized care through streamlined processes with empowered, connected patients and clients. And that, just as a wee taster of some of our narrative in the strategy deliverables, will be expanded upon in those documents that you'll be able to get access to in the course of just the coming few short weeks, certainly before the end of April. So we've talked a good bit here so far about our accomplishments, and that's just right. I think as a sector, sometimes we're not great at pausing to celebrate our wins, particularly given the temptation to focus on the inexorable growth in demand and the pressure that that brings to all of our roles. However, I just wanted to make the point that it's not been plain sailing across all of the last year. And I wanted to give a few examples of challenges that we've been wrestling with. So financial planning's one. We've had large amounts of slippage come back to my team, the DHCNI team, just in the last few weeks and months. And the causes of that are understandable. Challenges in recruitment would be one. However, it's probably the case that programs and projects were aware of some of those rate limiting factors and could have forecast a bit more realistically their ability to spend in Q3 and Q4 at kind of our halfway point after 6 months. And that slippage really maybe didn't need to come back at the magnitude that it did in Q4. Exacerbating the impact of all of that challenge is the lack of ability to use our slippage in the latter parts of the year to address technical debt as a productive way of spending slippage monies. The global chip shortage and the wider supply chain challenges this year means that rapid spending on technical items isn't really as possible as it once was. The sorts of mitigations that we're thinking for next year to resolve that, strengthening our financial planning and governance, getting more realistic on spendability in the first half of the year, and setting definitive targets on business case cut-off dates during the year to avoid programs starting later and therefore not being able to use the budget that we'd allocated to them in the plan. Finalisation and approval of the strategic outline case and development of the associated outline business case for their digital workplace programs continued to be a problem and has been delayed this year due to lack of resources, particularly in DHCNI. Mitigations for that this year and flowing into next year include appointment of external help from PA Consulting to try and progress that. The digital workplace program will see us make the best possible outcomes for you guys, for our staff, and for citizens from our investments in those Microsoft Office 365 licenses that bring us those collaboration tools like Microsoft Teams. Development of the VMware OBC. Not everybody will know about what VMware is. It's the products that allow us to deliver virtualized server environments. That's how we deliver compute facilities and virtual desktops and AirWatch for mobile device management. So this is a part of our technology fabric that's really useful and necessary as we modernize our technology estate. So that business case has had a number of issues, again, caused by capacity constraints in the system as we've been dealing with COVID. So the DHCNI team, a lot of the guys that are on the call today, the team that normally do all of the strategy and management of the portfolio, we've had to pivot them given the lack of ability and capacity to deliver all of these new agile processes and smartphone apps and whatnot for COVID. We've had to pivot that team to being a bit of a delivery shop over the last couple of years, and that's caused some friction as we've tried to stay up to speed with commercial and financial processes where for a wee while there have been some of our vendors that haven't been paid on time. So that's caused us reputational damage and a bit of friction in the marketplace. So we need to make sure that we're putting enough capacity into those activities and putting them on a more steady footing as we move into next year. The transition of the Health and Social Care Board into BSO under the closure of the board and the creation of the Strategic Planning and Performance Group. The DHCNI team aren't part of SPPG. They're managed under a memorandum of understanding that predates the creation of SPPG. While that is absolutely clear at principle level, there's a bit more work that we need to do at the implementation level to get total clarity on the relationship between SPPG and DHCNI. So that there's a little bit more work to do there as we move into the new year. Aligning with DOH policy initiatives. So there's lots of things happening that most of you might be aware of. If not, a bit of Googling will give you a bit more insight into this, like the urgent and unscheduled care review that was put into consultation recently, and the finishing touches that are being put onto the implementation plan for the new cancer strategy. So all of those things are coming out of the department, and if you go and read them, there's not as much digital in there as there really should be. So I think there's something that we can learn from that and do in the next 12 months as we think about how to align more strongly between the digital strategy gang and the DOH policy group. And finally, my last point, just in terms of some of the challenges this year, is around the longevity and stability of the NIECR product. There had been a bit of a sense that NIECR is going to be sunset as we roll into Encompass. And while that's true in the outturn, it's going to be needed until at least when we put in the 5th trust, which is over in 2025, and our plans at the moment on Encompass. So there's something that we haven't managed to really bring to total fruition this year in terms of the steps that we need to take to strengthen NIECR. So I'm going to move on to my third agenda item here, and I realise I'm at approaching the 40-minute mark. So I'll canter through this pretty quickly so we can get some time for questions. I showed you this picture earlier on and asked you not to look at the detail, but just take the point I'm making there about the size and magnitude of the investment that we're making and some of the things that were in that plan. As part of our year-end processes, we've gone back to those 30 big things and we've done the full reconciliation of what we said we would spend and actually what we've spent. And what you can see here is that we've spent on those 30 big things less than we'd intended to. So the reasons for that are, firstly, healthy and intentional in-year reprioritization of the portfolio, and reallocation of capital and revenue. For example, we realized in year citizen digital identity and analytics investments were largely delivered, or at least the building blocks delivered by our COVID investments, and the common identity framework was benefited by the work under the DWP technical enablement project. So there's no point in investing in those things when actually other activities were going to deliver outcomes. Other points in here are that our ability to appoint resources and build capacity in programs and projects and affordability of new resources in the central DHCNI teams was impacted by COVID. And colleagues across the sector had some of those same problems who are key enablers of transformation, like finance, approval and procurement processes. So COVID has continued to be a bit of an impactor of our ability to progress and therefore our ability to spend the money that we'd intended to. In the final section of my update here today, I just wanted to do a couple of things, provide an indication of the current financial plan as we look forward and some comments on why that's a current view rather than the final view, and a bit of a sense on our priorities for 22-23 outside some of this data-driven stuff, the portfolio financial planning, including some thinking on the factors that are going to restrict our system-wide ability to deliver all of these changes that are in the portfolio. So this eye test, amongst eye tests in the materials I'm sharing with you today, is the capital and revenue planning position as it sits today for 22-23. And as you can see, we are higher than both our going in and final position for last year, both on capital and revenue. The budgetary planning position for health and social care generally in the province is impacted by these significant inflationary pressures at the macro level, as well as a need to accommodate directly the continued costs for COVID in the pandemic response that continues into the next 12 months. And this puts us in a place where, in totality in health and care in Northern Ireland, we're about £750 million, or actually more, adrift against our baseline of about £6.5 billion. And without the Executive Assembly in place, it's really challenging to negotiate and prioritise a level of funding that allows us to react to some of these key priorities. The Department of Health Finance Directorates have been working with our outgoing minister to try and arrive at a level of funding that allows us to proceed into Q1 with coverage for all of those critical activities, even some of those that are above our budget baseline. This includes things like NIPIMS and NIPACs from the digital perspective, as well as continued funding for that HSC digital program that I talked about. We can't, unfortunately, count on this just yet, but we are imminently expecting a position that allows us to tip over today into Q1 of FY 22-23 with a little bit of confidence, albeit not a fully reconciled plan. And through wider budget planning processes, we're going to crystallise our annual plans and approve the digital plan, hopefully by the DHCNI board in June. So just then moving on, and then this is my final slide. Beyond all of this financial detail, I wanted to provide a bit of a sense of some of our priorities for 22-23 outside of this more kind of detailed financial stuff. And I'll do that just in a few points before I wrap up. So currently, we lack a question about how we're going to solve the data archiving across all organisations and systems. So as we migrate away from legacy, the archiving project will be established fully and is going to begin to make some conclusions about how we approach that. The strategy for development of the HSC Data Institute, which is talked about in the data strategy paper I mentioned earlier, and that was approved at the Rebuild Management Board in March. And the next steps are going to be carried forward in Q1 and Q2 in 22-23, including the development of the mandate and the business case. The review of clinical inputs to all of this digital stuff needs a bit of attention, and also the review of PMO capabilities across the portfolio, given that we're replicating PMO both in the DHCNI team and across every one of the programs and projects, plus in BSO ITS. So there's a little bit of a review of PMO capabilities that we'll do, given some of the shortages in capacity and capability that we're experiencing generally. We're going to explore an integrated portfolio change and benefits framework for digital investments. And the thinking here is that we're currently lacking alignment across programs and projects in the portfolio in how they approach change management disciplines. So the best example here for people to understand will probably be about communications, although training and leadership alignment are also key points. From a staff member's perspective, they're being deluged with multiple different communications from different programs, and it's a bit baffling and incoherent. We've had a series of discussions just over the last few months, resulting in an agreement for improved coordination of business change activities. And this sets out to do 5 things: to create a more aligned and coherent business change journey spanning the range of digital programs, solutions and services that will impact and improve the day-to-day experience of our staff. Secondly, to bring together change leaders from across the portfolio on a regular basis to align on a more consistent business change methodology, to discuss opportunities and synergies, and to identify and resolve challenges. For instance, recruitment and staffing issues that I've talked about a good bit already. The third thing that we're going to try and do is develop and maintain an integrated change plan with key business change milestones identified and any clashes resolved across the teams. The fourth thing is to assess and make recommendations relating to the magnitude of change that organisations and individuals are able to accept and adopt. And I'll talk about that in a wee bit more in a second. And finally, to assess any change bottlenecks where multiple programmes are seeking to employ support from teams across the service, like local trust HR teams, for instance, and work collectively to consider mitigations to some of those clashes. So on my point there about how much change we can deal with as a system, given all of the parallelism that we've got in the portfolio, we recognise that there's a lot going on, and that it results in a bit of anxiety about our ability to collectively achieve all of what we're planning to do. So the issue here is that we've got no real measure at the moment about what is the right amount of change, what could we deal with, particularly given what we've learned about the system's ability to change and adapt and adopt during COVID. So we're going to look at 5 potential factors around our ability to change and use them to establish a deliverable portfolio plan through our enterprise portfolio office. So those 5 things are funding, the capacity in program teams to deliver, the capacity amongst our staff to accept and adopt change, the capacity of our change enablers, and I've already mentioned Trust HR, but probably Trust IT would be one in there, to deal with the strategic and then the ad hoc asks to contribute to the multiple programs. And finally, thinking about the other non-digital change programs that put pressure on trusts and other organizations. So I'm going to draw my my presentation here to a close, and thank you for your time and listening to me bang on about our progress last year and our plan for this coming year. I realise that was a lot to consume, but I just want to stop sharing my slides here and give people a bit of an opportunity to ask any questions that have come up during the course of my presentation. Feel free to pop those in chat, or indeed come off mute and just jump in on the conversation.
Dan, can I ask a question?
Please do. I'd be a bit embarrassed, Linda, if nobody did. So thank you for that. Get the ball rolling.
You can always trust me to ask the awkward question. You mentioned a number of challenges throughout that recording, but what do you think is the biggest one? Is it the financial, lack of executive, maybe curtailing what is readily available until June? Is it the culture, or is it the resources not being available either internally or externally? Because the marketplace at the minute, even external to HSC, is quite chaotic. So just what's your thoughts?
Yeah, I think you've probably hit on the biggest challenges that I would draw our collective attention to. We'll get funding. We are sort of guaranteed funding according to our baseline last year. So what we went into last year planning to spend is pretty much bolted in terms of this year for capital and revenue. So we'll get some money. We need to make a play to get all of the money that we need, given that there's lots of programs that need to start spending in their delivery phase this year. And if you track back, there has been historic underinvestment in digital, in health and care in Northern Ireland. And there's evidence, for those that want to go and Google for it, in the Public Sector Shared Services Programme that identified that a good few years ago across the public sector in Northern Ireland, pertaining to our spend on technology in health and care. The timing there of the programmes that we need to deliver in order to address the technical debt that comes from that historic underinvestment just means that we've got this bundle of things that are coming in the next 2 or 3 years. So we've got a good case to make, and I think we'll be able to secure the funding that we need to do at least the very high priority items within the portfolio. Resourcing and capacity is our really big problem. And I probably, to answer your question directly, Linda, would call that out probably as our biggest challenge. If you look at what's going on in a program like Encompass, they needed to recruit 166 team members in the program team. There are more than that involved in the trust program teams, but just in that central program team, there's 166 heads, some temporary, but frankly most of them permanent staff members. And we've only been able to attract 100 people recruited so far, and we've gone through 5 rounds of recruitment to get to the 100. And I think, as most people know, we've brought in some external friends to assist us, some of whom are represented here. And that doesn't bode well for our ability. There's Kevin just popping his camera on. Hey, Kevin. It doesn't bode well for all of the other programs that are going to spin up this year. So I think we need to be realistic about our ability to deliver. And I think we need to maybe evolve our relationship with the market and think about how we're going to leverage vendors here in Northern Ireland to help us with some of those delivery tasks, rather than assuming that we're going to be able to recruit particularly temporary staff members into program teams. Thank you for the question, Linda.
Okay, thank you.
Dan, you can always bet on me for a question as well.
Thanks, Damien.
Just in and around the reform agenda, or the transformation agenda, you've very comprehensively described just how busy the system is at the minute. You mentioned cancer, you mentioned urgent and emergency care. Adult and social care reform is out for consultation at the minute. How do we balance struggling to do what's already on the plate with what's coming over the agenda, if I mix my metaphors there?
Yeah, that is a great question. I don't know how we develop in our team, the strategy team, the capacity to be able to reach into the department and have those conversations and be part of that journey and sit on those boards and remind people, not at the end of the definition of a bunch of policies, but kind of at the start, about how important digital and information are. I hope that two things. As the dust begins to settle on the pandemic, and we're definitely not yet there yet, anybody who works in a trust will feel that as much as we do in our team. But as we do start to see the dust settle, that should give us a bit more capacity. And I would hope that the things that we're doing already, Encompass as an example, will deliver the foundational digital capabilities that we need to enable any number of policy initiatives. And we'll find ourselves aligning on our digital strategy, which we can all review in the next few weeks, actually being a set of enablers that will allow the policy landscape to build on top of that. And therefore, we won't be finding that we've got huge differences between the policy requirements and our digital plans, that actually those things start to converge. But it's a bloody good question, Damien, and I frankly don't have a very good answer for it.
I think part of it, and I think part of that question for Damien is, I think some of these regional programs, we got to get live. I think part of it is we can design and test until we're blue in the face, but I think we have to go live with these regional systems. I think we all know it's never perfect day one. Like with the Encompass program, it has a longer timeline than maybe most, but I think it's critical that we get all these and some of these key critical clinical regional programs up in a production status so that we can help balance, like we have existing work and we're managing a hybrid and work environment. We've got multiple systems. If we can reduce some of this legacy work with newer systems that are being introduced, it's going to be a busy probably 3 years, I know, at least in the Encompass world. But I think once we get through that initial workload, Damien, I think we'll be in a better spot. So the next 3 years, we all know there's a lot to do, especially on the Encompass side.
I suspect people have guessed, Kevin, but you just want to, for anybody who's not had a chance to meet you before, do a really quick intro.
Yeah, sure. Absolutely, Dan. Hi, my name is Kevin Conway, and I am providing some executive support to the Encompass program, supporting Dermot Hughes, Dr. Dermot Hughes, who's the SRO of our program. Been with Encompass since the August timeframe, and just helping to navigate this program to our first go live here in Southeastern Trust. So thank you.
I think the really useful bit of Kevin's intro that he missed there is what he used to do before he was in this job. So he was the CIO of a major health system in North America, and also has done quite a lot of electronic medical record deployments, including in the English NHS. So good to have you on board, Kevin.
Yeah.
Catherine, you've got your hand up there. Did you want to come in with a question?
Yes, please. I just want to know, I suppose it leads on from both Damien and Linda's questions. Are there any plans to introduce some in-house project management training? Because I feel as though it would help to inform staff about that project path. It would make them more aware of how to cope with all the projects that are coming along. And it might, particularly clinicians who have been so patient focused, we need their engagement to deliver, Encompass in my case. So it opens their eyes to the world of project management, like particularly change management, you know, that's a science in itself. So I think we need in-house training. I looked in the leadership centre brochure the other day and there is nothing, but I think project management within healthcare itself is a separate beast. And we need people who are passionate and have experience in that area to promote it as a worthwhile career.
And you mean project management training, not for project managers, but for everybody else in the system to understand what the anatomy of a project is and what they're going to be asked to do and what that means. Okay. So I think there's probably a couple of things. One is we need to get really good at this coherent communications approach, rather than LIM's going to try and communicate with people and then NIPACs and then Encompass and then Equip, because all of those things are going to impact all of our staff members. That we do that in a more coherent way. I think your idea to say, here's the 101 guide for what the anatomy of a project is and what that means for you, I think that's a great idea. That's not a thought that has occurred to me. And I know just the lady who might put that on her to-do list. So I mentioned there's going to be this initiative around trying to be more coherent around business change across all of the programs and projects. And Linda McRandall, she won't mind me saying, has volunteered to step into chairing the Northern Ireland digital community of practice around change management. So Linda, I think Catherine's suggestion we can certainly air with that group.
Thank you.
Brilliant. Any other questions? We're just a minute beyond time. Anything else that people just wanted to share or ask before we bring this to a close? No? All right. Well, thank you very much for your time and dialing into our digital dispatches today. These are a monthly thing, so if you enjoyed this one, there'll be more to come. We've got videos of all of the previous digital dispatches that are up on the DHCNI YouTube site. I would also encourage you to go and have a listen to some of the DigiBytes podcasts on our SoundCloud channel, where we've interviewed some folks who've got interesting things to say, I hope, about our digital program. Have a great Friday. When you get to it, have a great weekend. Thanks, everyone.